Could you please hit record?
I got you.
It's a team effort. Hi, everyone on YouTube. Thanks for joining us. All right.
Oh, I'm so sorry about it. I'm having some trouble because it's my first time using this computer to do that. But
Please take your
let's
time.
see if it worked. Let me try again.
No worries.
I'm so sorry about it.
Oh, please don't apologize.
Mm.
Jack, do you want to just get started while Marian? Oh, there you go. Perfect. All right.
Okay, great.
I thank you so much. Aisha, the mic is yours.
Thank you. Okay, so I just want to preface that this case is from Dr. Ravi. So thank you so much for giving me the case and letting me present it. I hope I'll make you proud. Okay, so the first aliquot, we have a 48-year-old female with a syncopal episode.
All right. That's a great place to start. Syncope is something that we encounter quite often. I think there's two dimensions to the evaluation of syncope up front. The first is we always want to ask ourselves, was this indeed a syncopal episode or was it a syncope mimic? And then once we've confirmed that it's a syncopal episode, there's a variety of ways that we can think through the potential causes of syncope. But the approach that I oftentimes like to take is figuring out whether it's a orthostatic syncope, reflex or vasovagal mediated syncope, or cardiogenic syncope. But again, that's going to be a path that we navigate once we've confirmed or at least have a high probability that indeed this is a syncopal episode. Because the syndrome that syncope sits under is a syndrome that we can also look at as a transient loss of consciousness, right? So when someone syncopizes, they are awake. There is a brief period of time that they are not awake, and then usually they are awake again. And that awake to not awake, back to awake again characterizes a transient loss of consciousness. Now, transient loss of consciousness can be due to the 4S diseases, one of which is syncope. And then the other S's, I'll ask the group to put them in the chat as you think of them as well. But it's syncope, stroke, or TIA, seizure, and then sugar, with the sugar being hypoglycemia. And each of those carries one of, or each of those have a signature that includes a transient loss of consciousness or a transient change in mentation, but they also have some of their own individual unique signatures that help us differentiate them from one another. So again, we see a 48-year-old woman with a syncopal episode. We're going to approach this in two steps. One, is this indeed syncope, or is it another syncope mimic, the other causes of transient loss of consciousness, which is stroke, seizure, or hypoglycemia? And then once we've confirmed that it is indeed syncope, we can think about the potential buckets of syncope. But I'm curious, Sharmiz, what are you going to be looking for as the rest of this case unfolds to help us figure out kind of which of those transient loss of consciousness categories we're in?
I love that approach. I think a lot of the times, if you have a good history and you have a witness syncope, and the patient also can give you a history, there is a lot there that can potentially help you. Like for example, if you have had prodromal symptoms, that is quite helpful if you think about vasovagal category. With orthostasis, if the patient is like, oh, I was like getting up from a seated position, I started walking, I felt dizzy, like that is kind of classically orthostasis. And then with like cardiac, we think more about like, sudden without any kind of prodromal symptoms. Again, this can help you, but again, you want to do the workup, you want to put it in the context of the patient and their past history as well. But those are some of the things I'll be looking for in the HBI.
That's amazing. The conversation is so natural. I love it. Okay, so on Mr. Presenting complaint, she had the syncopal episode while she was working at home, and she regained consciousness after some time. And for the past 3 months, she has had exertional dyspnea, and she denied jerking movements and tongue biting. And for past medical history, she has hypertension, which is controlled with amlodipine. And in family history, there is hypertension and diabetes. She's not a smoker. She consumes alcohol occasionally, and she has no drug allergies.
Ah, right. Actually, you might not know the answer to that question. Do you know if she was like in a seated position when she fainted, or she was like walking around at home? No worries if you don't.
I'm not sure.
No worries at all. Thanks. All right. So it sounds like she had a truce. From what we can tell for now, I'm gonna try to categorize this as the true syncopal event. However, when people get to the ED checking their sugars and everything else, I'm looking for mimickers with a good neuro exam, for example, to make sure a stroke is ruled out. All of things is very valid. But for now, what I'm gonna do is just I kind of think about the buckets of syncope that we kind of mimic, and then I'm gonna have Jack think about the past history and also the dyspnea on exertion and how if it, at all that changes his framing of this case. So in terms of like syncope, and CP solver schemas I found quite helpful. We have like a 1.0 and a 2.0, and the 1.0 is like where I start, right? I think about the three categories: reflex, orthostasis, and cardiac. When it comes to your no miss diagnosis, all of them reside in the cardiac bucket. So especially in my line of work, when people are getting admitted to syncope, is because we want to make sure that cardiac etiologies are ruled out, and that includes arrhythmias, more often Brady arrhythmias more than tachyarrhythmias. Tachyarrhythmias like ventricular tachycardias can for sure cause it. In terms of SVTs or supraventricular tachycardia, most often if they cause syncope, there's another reason. Either like people are volume down or they have underlying structural heart disease. And then the other category within cardiac is structural. So think about, valvular pathologies, thinking about tamponade, thinking about structural abnormalities like Hocum. And then orthostasis is another really common etiology. I often think about it in two. One is autonomic dysfunctions. You often see it with like neurodegenerative disorders or like diseases like, diabetes that can cause like autonomic dysfunction at some point, but like Parkinsonism, for example, is a common one. And medications, right? Oftentimes medications that get into the combination of like being volume down or something that can cause it. Alpha blockers are notorious, but any blood pressure medication in the right context can make you pre-syncopal, and a volume. And then the last one is kind of reflex mediated. Like she didn't really endorsing any prodromal, and again, that is for me always a diagnosis of exclusion. Jack, what do you think about her dyspnea on exertion and her past history?
Oh man, it's such a good question, Sharmin. I think really solving that problem, or at least analyzing that problem, we have to do it in the context of how she's presenting, which is with exactly as you said, this syncopal episode. And I think to build off of what you were saying in terms of the importance of understanding what the probability is that the cause of someone's syncope is a cardiac cause is a key consideration whenever we're looking at a case like this. And so what I'm really looking at that question of what do we make of the dyspnea on exertion? I'm trying to answer the question of how does the dyspnea on exertion increase or decrease the probability of this being cardiac syncope? And I think my initial response is that it increases the probability of it being cardiac syncope. And the reason for that is when we're understanding someone's syncopal episode, each of those buckets that Sharmin mentioned, orthostatic, reflex mediated, and cardiogenic, they all have certain key features that make one category of syncope more or less likely. And it's worth having on speed dial some of the key differentiators that make cardiac syncope more likely, right? So in other words, what are the features of a syncopal episode that suggest a cardiac cause of that person's syncope? And there's really 6 primary features that are worth remembering, and we can organize them into 2 categories of 3. One category of 3 relates to who the host is with the syncopal episode, and then the other category of 3 relates to what is the syndrome of their syncopal episode. So basically, there are 3 baseline risk factors and then 3 features of the syncopal episode that can also suggest cardiac syncope. Those 3 key risk factors include a known history of structural heart disease, so heart failure, for example, or coronary artery disease, A known history of conduction system disease, as Sharmin was saying, is there a bradyarrhythmia or a tachyarrhythmia history? And then a known family history of severe heart disease like sudden cardiac death, right? So those are the things that help us understand who the host is. And then there's 3 features related to the syndrome of the syncopal episode itself. And if somebody has exertional dyspnea that is happening in or around the syncopal episode, that increases the probability of cardiac syncope. If somebody has supine syncope, as in they're lying down on the couch or they're sitting in the chair and all of a sudden they lose consciousness, that also increases the probability of cardiac syncope. And then the third one is if somebody has a syndrome of palpitations and then they syncopize, that also increases the probability of cardiac syncope. And so if we look at this case here, right, we don't see any significant risk factors, right? Hypertension, it's so common that it's hard to say that that really shifts the scales towards cardiac syncope. But the syndrome of her syncopal episode happening in the setting of exertion with this background of exertional dyspnea, I think does increase the probability, right? Does it mean that this is definitely cardiac syncope? Certainly not. But it does increase the probability in a way that we may now want to go hunting for some of the potential for some potential evidence of underlying cardiac disease, whether that is conduction system disease, structural disease, as Sharmin mentioned, or one that I oftentimes forget, the cardiac plus symptoms, which could be related to the pericardium or the pulmonary vasculature as well.
Amazing. You're on the right track for sure. You're definitely on the right track. So for vitals, her blood pressure was 110/70. Her heart rate was 75, and her O2 stat was 99% on room air. On general physical exam, she was awake and alert. She had moist mucous membranes. Cardiovascular, she had a normal S1, S2, and a 2 out of 6 diastolic murmur. There was no JVD present. And on pulmonary, it was clear to auscultation, no edema in the extremities, and neuro was unremarkable. And some basic labs. Her white blood count was 10. Hemoglobin was 11. Platelets were 450. Her sodium was 143. Her potassium was 3.9. And her chloride was 89. BUN was 18. Creatinine was 1.06. Glucose was 170. And her albumin was 4.0. Magnesium was 2.2. Calcium was 9.2. Alk phosphate was 104. Normal ALT and AST, and her GFR was 28.
Jack, do you want me to take the exam and that? Or
Yeah, go for it. Go.
Cool. All righty. Thank you so much. It's such an interesting case. So vitals being vital, again, the things that we were looking for any signs of like, bradycardia or tachycardia, again, but a lot of arrhythmias, again, can be intermittent, right? So one vital sign measurements should not reassure you that everything is fine. So this is a person that, when they're in the ED or in the hospital, you want to put them on telemetry if possible to be able to catch anything. And the other thing is like the ECG would be really helpful, again, because you want to see if there's any evidence of conduction disease at baseline. So looking forward to that data later on. In terms of like her blood pressure, about 110, she is on amlodipine already. And the other thing is like, again, looking at the back, if there's additional information to know where is she usually sitting. Is this someone whose all blood pressure is always in the 180s and now it's like 110s, or this is kind of normal for her? So those are the things that I'm thinking as I'm like looking at those vital signs. And the part of the exam that catches my eyes is the diastolic murmur. In terms of like diastolic murmur is always something to pay attention to. To be honest with you, if I ever can hear a diastolic murmur I feel like that is a big win for me in the day. I feel like these days I just rely so heavily on the echocardiogram, but kudos to the person who heard the diastolic murmur here. In terms of the diastolic murmur, you don't want to skip it because oftentimes always diastolic murmurs are pathologic. And the thing when I think about diastolic murmur, I think about whether it is due to stenosis or regurg. So thinking about mitral and tricuspid stenosis or aortic or pulmonic regurg. And again, like thinking about valvular pathologies, oftentimes we think most notorious like aortic stenosis causing a syncope. However, in the right context, a bad regurg for sure can lead to it. So that is again another clue that we should really, really pay attention to that cardiac bucket. The other things, as we're looking for an exam, again, this is someone who presented with dyspnea on exertion, but sounds like her exam was like clear to auscultation. Again, clear to auscultation, it just means it's we don't hear anything in the alveoli. But again, with getting a chest X-ray, at least Jack mentioned heart failure. I don't see any symptoms or signs of heart failure on exam, elevated JVP, lower extremity edema, crackles. So thinking about like whether this like valve pathology might be on its own and hasn't had further sequelae except the dyspnea on exertion perhaps, but that's where my brain's at right now. Jack, any additional thoughts?
No, I have nothing to add. I think you captured it. You captured it flawlessly. Yeah, that was awesome.
Just one more thing, sorry, I forgot to add this in the labs. Her pro-BNP was 250 and her troponin was 23. Would you like to discuss that or should I continue?
23, is that, help me with the scale. Is that, do you know if it's the like, is that markedly elevated troponin or is that the high sensitivity troponin and it's just like a little bit elevated?
I think it's normal.
Normal. Okay, cool. Thank you, Robbie. I get so confused by this. I'm like still old school with the the different scales. I'll maybe just touch briefly on what the BNP does, because I think what the BNP can really help us with is it helps to answer the question of whether or not somebody's dyspnea is related to a problem with the heart, and specifically increased filling pressures in the heart. The original studies for the BNP really used it as a way to determine whether somebody's a patient who was short of breath in the emergency room, whether the cause of their dyspnea was heart failure. And if somebody had a low or a normal BNP, it made it very unlikely that heart failure was the cause of their symptoms. And I think sometimes we end up extrapolating it to more based off of what we know about the physiology of the BNP, but that really is what it is most effective in helping us answer. And I think what this tells us is that the elevated BNP tells us that we can't take the heart off the hook as the cause of her shortness of breath, which, as Sharmin has already, I think, brilliantly articulated, we have a very strong consideration for based off of the murmur. Right, the BNP ends up being released in the setting of atrial stretch, and that if there is indeed a lot of atrial stretch in this individual's underlying condition, right, that may increase the probability of some of the murmurs that Sharmin talked about. For example, people who have mitral stenosis can get very, very large dilated atria, and that could lead to high levels of BNP. But for the same reason, people also who have aortic regurg can also get a high BNP because there's so much regurgitant flow back into the left ventricle that may lead to congestion back up from the ventricle up into the atrium. So I think the BNP really supports our hypothesis that the heart is on the hook here, but it doesn't necessarily tell us what ways the heart is on the hook yet. I think exactly as Sharmin was saying, we need echocardiography and maybe also electrocardiography to help make some progress on that.
I love that, Jack. The one and only Yusuf, do you want to just unmute and make this, like, tell everyone what you put in the chat? Because I feel like that is a fantastic point.
There was a study where they evaluated CTPEs on patients who had their first syncopal episode, and up to 17% of patients had a PE, which is 1 in 6 patients. That does not necessarily tell us that the PE was the cause of the syncope, but amongst those patients, 1 in 6 had a PE.
Yeah, that's such a great point. Just such a good reminder that so many, every time I think it's a PE, it's not a PE. Every time I don't think it's a PE, it's a PE. So I feel like it's like always a good reminder to think about that. And someone who's coming in with dyspnea on exertion, a regurg that is pulmonic in nature, then you know, I think it's like a fair thing to consider. Thanks so much, Yusuf, for putting that on our radar. All right.
So I just have the ECG and chest x-ray, and then the echo reveals the diagnosis. So I won't reveal the diagnosis yet. I'll just tell you EKG and chest x-ray. ECG was normal sinus rhythm with right axis deviation, and chest x-ray was unremarkable. And then I have the echo results. Would you like me to say them? Okay. On echo, there was a left atrial mass measuring 4 by 2 centimeters attached to the interventricular septum with movement along the mitral valve. And the patient was admitted for further evaluation of her syncopal episode, and a TEE was performed to better characterize the size, the location, and the characteristics of the mass. And that showed classic characteristics of a cardiac myxoma. And a decision was made to surgically remove it.
Wow. So just so make sure I understand, there was a mass near the mitral valve? Got it. Okay, so thinking about like that is leading to mitral stenosis that is attributing. So that's what the diastolic murmur that they were hearing was from the mass itself. Whoa. And it's like probably most likely it's causing a difficulty with flow, and probably that caused her syncope. Wow, Jack, any thoughts, friend?
No, I think, I love cases like this when the pathophysiology ends up making sense here, right? Because we could ask ourselves, well, why do her symptoms come on in the setting of exertion? And we can almost think of, right, in the same way that people get reduced cardiac output, or in other words, reduced filling of the aorta in the setting of aortic stenosis, people can get reduced filling of the ventricle in the setting of mitral stenosis. And whether or not there is sort of permanent mitral stenosis, I think it seems plausible, as you were saying, Sharmin, that this mass is obstructing normal flow from the left atrium into the left ventricle. Under normal resting physiologic conditions, the LV may be getting enough filling, even despite this limited flow across the mitral valve because of the mass, that there is enough filling of the left ventricle to maintain a good effective stroke volume for resting conditions. But once she starts to exert herself or starts to exercise, right, there's two things that happen. The heart pumps faster, which means that diastolic filling time reduces. In other words, to get an adequate stroke volume or adequate filling into the left ventricle, blood has to be flowing faster. But if there's a fixed limitation of how quickly that flow can come across, we can get underfilling of the left ventricle, both because of the flow isn't coming fast enough into the LV, but there's also not enough time for the LV to adequately fill. And then that could lead to exertional dyspnea, or in this case, some element of exertional syncope. So I feel like there are many cases of cardiac syncope that I see that don't make sense, but this one has a very elegant pathophysiology that, one, helps us understand some of the features of cardiac syncope, but then also helps us make sense of how this case came to unfold. There's also probably another component of exertional syncope, which is that when we exercise, we get peripheral vasodilation as well, right? All of the vessels up into our brain, but also into our periphery vasodilate, which helps optimize blood flow to the muscles that we're using. And so that combination of reduced cardiac output and peripheral vasodilation is a two-hit that ends up leading to syncope in these settings here. So yeah, this is a phenomenal case. Aisha, thank you so much for bringing it to us. And yeah, it really was a blast as always to get to think through it with everyone here. And Sharmin, always super fun to get to talk with you.
I'm always, no matter how many times I hear you discuss, Jack, just the elegance, the way you explain things is just so freaking fantastic, and I love it. And someone's like, I think it's just flow that happens. And then Jack just like gives this beautiful explanation, which I absolutely love. Thank you so much, friend. Aisha, that was such a fantastic case. Thanks to you and Robbie. Mariana, thank you so much for scribing. And Mark, I can't wait to hear your teaching points.
Yeah, thank you for this amazing case, Aisha, and thanks for the great discussion. Learned so much from you guys. So we first started with a 48-year-old female with syncope. And then we learned that before we enter that world of syncope, we first want to frame the problem as a transient loss of consciousness. And we're thinking about syncope versus syncope mimics. And then Jack taught us and reminded us of the mnemonic, the 4 S's, that being syncope, stroke or TIA, sugar being hypoglycemia or seizures. And then we learned that history is really key here. All these 4 differentials have very distinct signatures, like a prodrome for vasovagal, positional with orthostasis. So really taking a good history is key. And then we kind of dived into the buckets of syncope. We started with reflex syncope, orthostatic syncope, and then cardiac syncope, which further we broke down to structural or arrhythmia. And then again, each bucket had features that, make it more likely or not. So for example, we learned about, some features that were more suggestive of cardiac syncope. We thought about two buckets, the host and the syndrome. So for the host, things that make cardiac syncope more likely is if you have a history of CAD or heart failure, a history of conduction abnormalities, or a family history of sudden cardiac death. And then again, our syndrome, we think about if a patient has exertional dyspnea, supine syncope, or palpitations, that will also push us more towards cardiac syncope. And then we move to the exam. We learned that a normal heart rate doesn't rule out arrhythmia because many arrhythmias are intermittent. So it's very important to put these patients on telemetry and also get an EKG as well. And then it's very important to know a patient's baseline blood pressure, because a patient could be normotensive, but for them, that could be a relative hypotension or even hypertension. So always know the baseline. And then we are presented with a 2 out of 6 diastolic murmur. And we thought about, what could cause a diastolic murmur? First, always important to remember, they're always pathologic. And it could be from stenosis of the tricuspid or mitral valve or regurg of the pulmonic or aortic valve. And then we moved on to the labs. We talked about the BNP, how this is really a good test when you're working up dyspnea and evaluating for a cardiac volume overload cause of dyspnea. And then Yusuf taught us that, a P is a very underappreciated cause of syncope, especially in inpatients. One study, 17% of patients with syncope actually had a PE. And then finally, we moved on to the TTE that showed a mass near the mitral valve concerning from atrial myxoma, really causing physiology very similar to MS. And then Jack kind of taught us how the physiology of exercise caused these symptoms and worsened that obstruction. Such a great case. I learned so much from you all.
Mark, that was fantastic. Thank you so much for doing the teaching points. So good. I'm just always amazed about how you guys succinctly capture the teaching points live. It's such a hard skill to have. Mad respect. Thank you. Aisha, I think you also wanted to share some reflections about the case.
Yeah, thank you so much, Mark, for those teaching points. I just, when I was preparing the case, I read a lot about cardiac myxomas, and I learned a few things that I didn't know before. So I just wanted to share those. So when I was reading, I found that there's 2 morphological forms of a myxoma. So there's a polypoid form, which causes the obstructive features, and then there's papillary, which are more prone to embolization. So it makes sense when there is a cardiac myxoma in the left atrium it obstructs the mitral valve, which leads to syncope. If it's in the right atrium, it obstructs the tricuspid valve, which shows some signs and symptoms of heart failure. So I just thought that was very interesting according to which valve and which chamber it's located in. But thank you so much for discussing this case.
Oh, thank you so much for bringing the teaching points, Aisha, and the case. Really appreciate it. All right, all. Thank you so much for joining us today. It was such a blast. We can't wait to see you next time. Have a wonderful day. Bye.